Thank you, Lisa, and hello, everyone. Good afternoon. I'm delighted to have the opportunity to introduce our next speaker. If you have any connection to public health or infectious disease control, or if you've seen any COVID pandemic newscast in the last 18 months, you've probably heard the name Michael Osterholm. Dr. Osterholm is Regents Professor, McKnight Presidential Endowed Chair in Public Health, and Director for the Center of Infectious Disease Research and Policy in the School of Public Health at the University of Minnesota. Since November of last year, he has served as an advisor on President Joe Biden's 13-member transition COVID-19 team. It is not his first service to a sitting president, however. He's also served the National Science Advisory Board on Biosecurity, the Advisory Council on Public Health Preparedness, and the Centers for Disease Control and Prevention. Dr. Osterholm's journey into public health began in his small hometown in Iowa. A local newspaper editor at the time shared with him stories from The New Yorker, which detailed outbreak investigations from the annals of medicine, and he was hooked. His desire to become a medical detective led him to Luther College, then the University of Minnesota to study epidemiology, and the rest, as they say, is history. Dr. Osterholm is the author of the New York Times bestseller, Deadliest Enemy, Our War Against Killer Germs, which explores emerging infectious disease and the threat of a global flu pandemic. For his work in the discipline, Dr. Osterholm has received more honors and awards than I can possibly list here with you today. We are fortunate to again have him a speaker at Nobel. Please allow me to present to you Dr. Michael Osterholm.
Hi. Thank you very, very much for the opportunity to be with you again some 15 years later after my previous presentation to this very important and very special meeting. It's a true honor for me to be back with you to report on a topic that I addressed 15 years ago, namely that of pandemics. This year, talking about it more from the concept of data and what does it mean as we relate through this pandemic with public policy, scientific findings, and public action. The title of my talk, From the Village Watchman to Actionable Data, A Challenging Journey, really is all about how are we using the information we have today to make the very important decisions about this pandemic. Today, I will cover with you in this talk a description of what are data, something I think we all understand what we know data to mean, but what does it mean to others? A brief description of influenza and coronavirus pandemics so that in fact we have an understanding of why data needs are so important. Understanding the black box use of data, namely that of modeling, something that's become a very common used tool in public health and public policy today, but questions really remain about its utility. The misunderstanding and misuse of data. I will share with you today one of the systems we use in this country to survey for potential safety signals from vaccines being misused by those who want to purport that the vaccines are dangerous and not effective. I'll talk about the issue with data from clinical trials influencing practice. It's the source of great challenge today when in fact we can have clinical trials well conducted, the gold standard of scientific research be dismissed, and other types of treatments or public health practices being proposed when the data, in fact, are lacking that they work. And then finally, talk a bit about poor quality data and its interpretation, how it confuses the public. I think public health really has done a very poor job of helping the public understand the role that masking may play in reducing the risk of transmission of the SARS-CoV-2 virus, and how we as a society have now made masking such a divisive issue in our communities. In terms of the issue of data, what are data? Well, it's a four-letter word that's very important to medical research and public health practice. It's our gold. Well, in fact, if you define data from Merriam-Webster, you see it's factual information such as measurements or statistics used as a basis for reasoning, discussion, or calculation. Let me remind you that reasoning, discussion, or calculation. As you'll see today, data has come to mean different things to different people. and they are firmly held beliefs about what those data mean. In the late 1800s through World War II, Sir Josiah Stamp, a British economist and statistician, shared many issues of wisdom with us around the use of data and how government takes data and develops public policy. And one of his most famous quotes, he said, "The government are very keen on amassing statistics. They collect them, add them, raise them to the nth power, take the cube root and prepare wonderful diagrams. What you must never forget that every one of these figures comes in the first instance from the village watchman, who just puts down what he damn pleases." In fact, today you'll find that that is unfortunately far too often the case, and yet we make some amazing public policy decisions based on these data. So let me first give you a brief description of influenza and coronavirus pandemics, just to make sure that we're all up to speed on why these data needs can be complicated. In fact, in 2017, I published this book with my co-author, Mark Olshaker, Deadliest Enemy, Our War Against Killer Germs. In that book, on chapter 13, the title was SARS and MERS, a harbinger of things to come, talking about the concerns that we had about what the future world might look like with the coronavirus. In chapter 19, pandemics, going from the unthinkable to the unbelievable. In that situation, we tried to lay out what might be the future with a pandemic and how we need to be better prepared. Well, I can say that we actually fell a bit on deaf ears. And hopefully today, people now have a beginning of an understanding of what it means to be prepared for the next pandemic. We've worried for all these recent decades about influenza viruses as being the cause of the next pandemic. Surely, I reported that in the 2017 Deadliest Enemies book. But at the same time as doing that, the principles really held true about a new virus emerging from an animal reservoir that then quickly swept through the world. In this case, we've worried for some time about quote unquote avian influenza, a virus of birds becoming, in fact, one that was capable of transmitting to and by humans. We all remember the famous 1918 influenza pandemic, chronicled here by historian John Barry, the Great Influenza, such a dramatic event that occurred in 1918, literally reshaped the world. It's often not recognized that, in fact, even though the 1918 influenza pandemic was only present during the last several months of the war, World War I, there are more American soldiers buried in Europe as having died from flu than the entirety of the war itself. Well, when we look at past pandemics, all caused by influenza, or likely caused by influenza, we've had 11 of them in the last 250 years. This is now not including the coronavirus pandemic. Onset of pandemics were distributed throughout the season. 3 started in our winters, 2 started in spring, 3 started in summer, 3 started in the fall in their respective hemispheres. The incidence was characterized by waves of illness and eventually part of the seasonal influenza picture. The 2009 H1N1 pandemic resulted in the absence of other influenza viruses and respiratory pathogens worldwide. One of the things we do not understand is why, when a new virus causing a pandemic takes off, all the other respiratory viruses we see disappear. And as you see through these pandemics, it wasn't because of mitigation strategies or vaccines. We don't understand this at all. If you look at the 1918 pandemic, you can see these 3 waves that were well described, in some areas as many as 4 waves, with a spring wave that occurred particularly in certain parts of the United States, and then the big fall wave worldwide that was so devastating, particularly in among young adults, and then subsiding well into late winter, early spring, and then coming back again in the late spring through the fall of 1919. If we look at what happened in 2009 and 10 with the new H1N1 influenza pandemic that emerged, you can see there, looking down in 2008, there was influenza activity that was normal seasonal flu, including influenza A, H3N2, H1N1, the previous strain. And if you can see there in those lines, this is actually what we'd expect to see by week of the year. So week 10, meaning that it's the 10th week of 2009. And then, as we would expect to see most flu seasons dropping off, and then all of a sudden H1N1 appeared from Mexico, It took off in that first spring wave in the late spring, early summer of 2009. Primarily those black boxes, the bottom boxes below it were influenza A viruses not typed, almost likely to all be influenza H1N1 pandemic. And then you can see how it actually began to wane in the summer, coming back in late August, and then that big peak that occurred between mid to late August in many parts of the world, and then subsiding quickly as we got into October and November. And note, through the winter of 2010, virtually no other flu activity, and there was no respiratory syncytial virus activity or any of the respiratory pathogens we normally see. Of note here, remember that there was not any special mitigation strategies going on at that time. No masking, no distancing, no closings. One of the things that helps understand what role vaccine played, this is a slide from a report that we put out after the 2009 pandemic. What you see in the blue line is actually on the right-sided vertical bar, the percent of visits for influenza-like illness to doctors' offices in September, October, which is really a marker for influenza activity itself. And you can see how it peaked in mid-October and came down quickly. If you look at the actual vaccine doses shipped and administered, with your left vertical bar being the scale, you can see that most of the vaccine did not arrive until well after the peak was coming down. And more specifically, many of these doses of vaccine administered really have to be, in a sense, cut in half in terms of the number, because they were pediatric doses where we were recommending 2 doses of vaccine. Bottom line message is vaccine have very little to do with this particular epidemic situation through the early winter of 2009-10, and just points out that this virus was doing what it was doing without any real impact from humans. To try to understand what the pandemic might look like in the coronavirus world, this is an article that Drs. Chris Moore, Mark Lipsitch, John Barry, the historian, and I published in April of 2020, trying to understand what a coronavirus pandemic might look like given to what we know about influenza. And we laid out basically these 3 scenarios. Might it be just a series of peaks and valleys until most people were infected or we had a vaccine? Would it be like in a classic influenza model, particularly 1918, where we saw an early spring wave, it came down, then we saw a big fall wave, and then basically started to reside as most people became infected? Or would it be something where it just kind of was a slow burn, just kept going and going and going and going? Well, we don't really have a model for it today. In fact, I would tell you globally, we continue to see what I consider a ongoing kind of whack-a-mole type of event, where we're constantly seeing cases increase in some parts of the world, decrease in others, so that we basically fluctuate between 2.5 million and 5.5 million new cases reported per week. And we see in countries, the surges occur where they come and they go, and we have no real understanding why. It cannot be attributed to human behavior as much as we'd like to think so. And even when we have very high levels of vaccination, for those who are unvaccinated, these surges continue to occur, just as we're seeing now. If we look at the epidemiologic case map here and case count, you can see, in fact, that over the course of the pandemic from early 2020, we saw this initial activity in April, May, which at that time was primarily located in several metropolitan areas, particularly the New York City area, Atlanta, Chicago, and New Orleans, and then some in the Northwest. And then you can see we got into late summer last year, cases peaking and then coming down by roughly late Labor Day, but really at a level that was a baseline of 10 to 30,000 cases reported per day. We saw the big late fall, early winter peak of last year, just before vaccines arrived, and then case numbers coming down precipitously. And we got to the period of late June, and everyone said, ha, see, we're done. We have vaccines now. And of course, as we pointed out over and over again, with this virus and now the new variants occurring that are much highly infectious, you can see what happened. In fact, the case numbers took off, and you're so well aware of this current surge. Right now, the pandemic, as we see in the United States, and for that matter throughout most of the world, is a pandemic of the unvaccinated. Now, this series of figures gives you a sense of why people who will make predictions about what's going to happen with cases really have an immense challenge. These are data that were reported here from June of 2021. And this is actually the 7-day average of new daily cases per 100,000. So the darker the colors, the higher the number of cases. And you can see what it was like in June. The country was feeling pretty darn good. We were in great shape. And then just 1 month later, on July 4th, the activity started to pick up primarily in the Ozark area of Missouri, Arkansas. And we started to see activity pick up a bit in the western states, although low population density areas. And then from July 4th, as you can see as we go further here, now we're at a situation where the southern Sunbelt states are starting to light up with ongoing transmission occurring in the Ozark area. And then by July 24th, you can see how the southern Sunbelt states are now really lighting up. And this is where we begin to see major challenges in healthcare delivery in terms of large population numbers. The Ozark area is still a challenge, but lower population numbers. And then by July 31st, we see the Northwest beginning to light up more in the far Northwest. We see the southern Sunbelt states hit very, very hard. And then by August, you can see what's happening here now. We see really filling in and now beginning what I like to call viral or lava flowing northeastward and from the Northwest flowing kind of eastward. And then you can see here as we get into August and in the late August time period, this now has spread upwards. We're now into Tennessee, Kentucky. West Virginia is about to become the most hit state in the country. And yet the Northeast is largely spared. The upper Midwest is spared. The southwestern part of the country, particularly in LA and that area, with limited activity there. And now here we are on September 2nd, and you can see what's happened. This has just continued to migrate through. The hole in Nebraska is not because of an absence of cases, it's an absence of surveillance. Now where we're at today, we today unfortunately have a situation where the upper Midwest is hot on fire. Alaska has the highest incidence reported at any location in the world during the period of the pandemic. We're now beginning to see New Hampshire, Vermont, Massachusetts, and Maine start to show major increases, whereas in the southern Sunbelt states, case numbers are decreasing. If you look at Minnesota, Wisconsin, northern Michigan, and North Dakota has now become the hotspot as of October the 1st. The point being is this is just migrating through the population in a way that no one could have predicted this. There is no model that could do that. So let me get to the understanding the black box use of data for modeling. This has been a real challenge. I've had over 40 hours of graduate statistics. I know a little bit about modeling, and I must tell you that more often than not, I find it a real challenge as opposed to a helpful tool. Why is modeling important? Because we want to predict the future. Why do that? Because we're planning for medical care resources, we're planning for supply chain interruptions, decisions about mitigation strategies, public education, reduce risk, managing public expectations. And these are all important. How do we predict that future for the public? Models have now become the mainstay for such predictions. Well, the problem with this is the unknown, the virus. As I've said over and over again, we're riding this tiger, we're not driving it. All that you just saw in those figures or those maps really had very little to do with we as humans were doing. Basically, vaccination surely does prevent the vast majority of cases from occurring. But in terms of the unvaccinated, this virus will be a sprint virus lasting for 3 to 5 weeks in a given area. And then for reasons it's unclear, basically just ends. We've been through multiple surges where it's not that it burnt out all the susceptible population. We don't know why it stopped. If we look at the variants today, we know, of course, with Delta, we now have this increased transmissibility, potentially increased disease severity. This has been a challenge in how it impacts our diagnostics, our treatments, or even our vaccines, as you're so well learning. Pandemic public health measures also are unclear. How much does testing and quarantine really make a difference? How much does masking and distancing make a difference? I will tell you today, it is very unclear. Finally, the vaccines themselves. What kind of vaccines? Is waning immunity important, as you've just recently heard? Boosters, what we need to do. What is the public trust to take a vaccine? These are all unknowns that have to be considered when looking at modeling. When we look at the modeling world, I've given you 4 different examples here. We could take many more, but I think it really helps understand the challenges of modeling and how in a public policy world, this has been a real issue. For example, the Imperial College COVID-19 response team model, some of the very best minds in modeling and statistics are in Imperial College. On March 16th, 2020, this is the model that really set the world on fire in terms of, oh my, what's going to happen? They predicted 2.2 million deaths in the US in an unmitigated scenario. The deaths in the US of October 3rd, 2020 were only 700,000. Now, when you see this figure, you can understand how people went, oh my, we need to do something immediately, based on the fact that they reported that likely 2.2 million Americans would die over the summer of 2020. And this is their different model projections. Again, best what they could do, but look at the difference between what happened. As I pointed out, 700,000 deaths today, they were reporting 2.2 million deaths just in those few months of the summer. Now, clearly, this report jarred the US and UK into action, but it's also challenged us with policymakers who said, wait a minute, you told us this was going to be a lot worse. It was bad. But how can we count on the information you provide? Same thing is true here right in the state of Minnesota. Our Minnesota Department of Health, the University of Minnesota School of Public Health, of which CIDRAP was not involved with any of these activities, put out modeling in April of 2020, again, to help plan for what might be anticipated. The models projected between 22,000 and 50,000 deaths in Minnesota by March 22nd of this year. Actual mortality at that point was 6,782. Now, if you look at the different scenarios as they laid out, again, many assumptions were made with estimates of uncertainty, grant you, were there. Whether you sheltered in place, so that was the SHO you see there, and whether you had physical distancing, etc. But these numbers came to mean something very specific to our policymakers and to the public. And when you look at the actual mortality as of March 22nd, as bad as this pandemic has been, I'm not trying to minimize it, but the 6,782 deaths in Minnesota compared to 50,000, 41,000, 22,000, 22,000, 20,000, and 22,000 by the different scenarios, even with the confidence intervals around those, only one scenario even had a lower bound that actually faced the sense of reality with what we had. And so I have heard many times from policymakers, well, you guys, we can't count on you. You just, basically we put into place emergency powers. We did all kinds of things based on these scary numbers that never materialized. I think 6,782 deaths is a scary number, but it is in reflection to what was proposed, not. The next area that I have real challenge with is the Institute for Health Metrics and Evaluation at the University of Washington, probably the most heralded group, the group that gets all the publicity. This is a group that has been wrong so much. This is a group that basically has been challenged by colleagues, and yet the media use them over and over again. On March 26th of last year, they projected over 80,000 deaths by July 20 of 20. Well, the actual deaths by July 2020 was more than 128,000. They missed that one. They also projected that the first wave would be over by June of 2020. Well, you see there, the June wave was not over, and in fact picked up through the period up to Labor Day. Then, if you look here, the same thing, they actually said US hospitals could be overwhelmed in the second week of April by demand for ICU beds, and US deaths could total 81,000 by July. Now, this is March of 2020. This is what helped put in place, and this is the data that the president used at that time, President Trump, to put into place the stay-home order, shutting everything down nationally. And then in many places in the country, COVID didn't show up at all. And there was such anger because places had to shut down. Mom and pop's hardware store had to shut down. The big box one did not. And again, a lot of this was based on modeling that was so far off. And in fact, many of my colleagues and I have criticized this. This is an article from April of 2020, in which, if you go into the full depth here, colleagues criticized this at some length in terms of the data that were being put forward by the group Health Metrics. If you look here, the other thing that they've added in their models has been the impact of universal mask use. As I will share with you in a moment on masking, there is no way to know the impact that masks actually have in reducing the number of lives lost. And for them to put this in here, is really truly black box. It's, pixie dust added to an analysis that then now is what's on the media every night. If I'm sounding very firm on this one, please know I mean this to be, because this has been, again, another challenge for us, is this misleading information. And then finally, if you look at the IHME's estimates, they often project out many months in advance, which would be like me saying, what will be the temperature on January 15th, 2022 in Minnesota? Well, if I said it's somewhere between 60 below and 60 above, I'd probably be right. But what good is it? And if you look here, the data up that line as of today is where they're projecting. The middle line is coming down, basically kind of leveling off through January. The top one is the worst scenario. The bottom one is if people wear masks, which again, they don't have any data to actually support those mask recommendations. And so everything to the left of that was actually what ended up happening, not what they projected. But what good is a model that is 5 to 6 months out, where the uncertainty is so large, anywhere from 3.5 or to 3,500 deaths a day down to less than 300 deaths a day? Yet this is what gets lots of publicity. These kinds of models have given us lots of bad names. Finally, the Centers for Disease Control and Prevention actually has done the best job, what we call the ensemble model, where what they've done is working with partners who are doing all kinds of modeling, bringing this all together, in which their methods are fully scrutinized. They've developed independently and shared publicly all these different groups, and they bring it all together in one forecast, and they never project more than 4 weeks out. If we look here, for the top one is the new weekly deaths, and what you see there, all the different groups who have contributed their models, and what you see basically is what actually has happened, and then the actual model itself in terms of what there is, that line that you see, the green line that goes through there, basically is what they project will happen through the middle of October. The same thing is true if they look at the bottom with total deaths. And so the one on the far upper right side is that summary model, which shows it likely peaking in early October, coming down somewhat in cases, deaths continuing to climb, however, through the mid-October, because death is a lagging indicator, often occur several weeks to a month after cases actually begin to peak. Now, this is responsible modeling. So I don't want anyone to walk away saying I'm just against modeling, but it's the best we can get. So just remember, all models are wrong. Some models are useful. Modeling as a public health tool can be helpful or detrimental to our response to an epidemic, pandemic. I think we've had a lot of irresponsible modeling going on that has gotten lots of public play and has not helped us. Assumptions. When people realize just how many assumptions have to be made for these models, I think it's very sobering. How do we communicate the variability? How do you communicate? Well, somewhere between X and 10X or 100X. And what does that mean? And understanding the strengths and limitations of modeling, something we do not do a good job of portraying. We portray them as if somehow there is certainty with these. And that public messaging and communication has been a real challenge, particularly among policymakers who don't forget the very errant models that were used early on and the downside that they now have served us because they've created a challenge to our credibility. Let me just say something about the misunderstanding and misuse of data in terms of intentional misuse. And this really relates to the vaccine safety and the vaccine adverse event reporting system, VAERS. VAERS is co-managed by the CDC and the FDA. It serves as a national early warning system. It was established in 1990 to detect any potential safety problems in vaccines that are authorized or licensed in the United States. What happens is the CDC encourages the reporting of by any medical care provider of any medically important adverse event, even if it isn't clear if the vaccine caused the heart problem or the health problem. So for example, I have a heart attack 10 days after a vaccine. Even though I might expect to see heart attacks in a group that got the vaccines, I have to report that. VAERS cannot assess causality or prove a vaccine caused a problem. What it does, it just sends a signal. If you suddenly start to see certain kinds of events occur, we need to very quickly and thoroughly investigate those. VAERS is useful for identifying a potential safety concern that should be investigated further. So what's happened though? If you look at anticipated events, just think about this. Even in the absence of a pandemic, morbidity and mortality is an everyday occurrence. For example, if we took a random sample of 1 million US residents 55 to 64 years of age, the groups that we are recommending vaccine for, we would expect the following to occur on a weekly basis: 79 fatal heart attacks, 74 strokes, and 171 deaths from all causes. That's actuarial. That's what life insurance is about. That's what would be expected to occur with no relationship to a vaccine if a vaccine hadn't even been given. Monitoring background rates and discerning whether changes are occurring is a critical piece of evaluating vaccine safety. So what's happened? There are a number of people today that have taken the VAERS data and said, look, at vaccine-related fatalities exceed 6,000. Well, yes, people have died who are reported to VAERS because they die from a lot of things. 6,000% increase in reported vaccine deaths first quarter. Well, in fact, that's just people are getting vaccinated now, and people are also living their lives and some are dying. Even here in Minnesota, I've had to deal with this issue where we have political figures who knowingly are saying that, in fact, these vaccines are causing deaths. One of our state senators claimed a federal database shows that there's been more than 200 deaths in Minnesota from the vaccine. This chiropractor knows very well that's wrong. He knows that. And yet this misinformation is out there. There is no evidence that a single person has died from this vaccine in the state of Minnesota. In fact, we have data showing that the vaccine has prevented at least 140,000 COVID deaths and 3 million cases. That's through mid-August. And those numbers continue to increase. Let me move on now from data with clinical trials influencing practice. Here we have the situation with the drug ivermectin. If we look at this in terms of clinical trials in the court of public opinion, efforts to identify safe and effective prophylactics and treatments have been undertaken since the beginning of the pandemic. We have an antiviral, remdesivir. We may have a new one that may likely be approved by the FDA very shortly from the Merck company. We've had monoclonal antibody treatments, Regeneron, which are now being used widely, all based on clinical trial data. Authorization and approval typically hinges on data from randomized, double-blind, placebo-controlled trials. COVID has challenged the standardized procedures, however, involving a balance of speed along with rigorous review. For example, early on, hydroxychloroquine, which is an antimalarial drug, not for a virus, was approved by the FDA for reasons that we can have a long discussion on, but a strong push from the administration at the time. The authorization was eventually revoked when the data were clear and compelling. It provided no benefit. Convalescent plasma, the authorization for that was actually limited based on the fact that the data were only sparse as to how well that worked and the positive impact it had. And in fact, ivermectin, which is an anti-parasitic drug, was not authorized at all. Ivermectin has taken on a life of its own, often among those who are anti-vaccine. And in fact, the FDA in August put out a statement, rapid increase in ivermectin prescriptions and reports of severe illness associated with the use of these products containing ivermectin to prevent or treat COVID-19. This became, I should say, the drug du jour, for which there were no data based on sound clinical trial studies that demonstrated that this had any benefit. It became kind of that popular culture drug. And in fact, the adverse effects associated with ivermectin misuse and overdose are increasing, as has been shown by the rapid rise in calls to poison control centers of overdoses. This is an anti-parasitic drug that can be used in humans in very limited situations and more often than not used in animals. Numerous clinical studies with ivermectin shown as an intervention are ongoing, but in fact, results from all the studies completed to date have not supported its use at all. The latest Cochrane systematic review in ivermectin on July 28th evaluated 14 studies with 1,678 participants. The conclusion, bottom line, overall, the reliable evidence available does not support the use of ivermectin for treatment or prevention of COVID outside of well-designed and randomized trials. In fact, one of the studies that received such attention and actually was a major influence on meta-analysis, combining of different studies to come up with results because it was so large, was a study that was actually shown in the end to be fabricated, and that has now been withdrawn from the medical literature, but it continues to be used. And this was by far the largest of the studies done to date, so it appeared to have a lot of influence. This type of issue, again, is a real challenge when you have a study that has been debunked for fraud, and yet it continues to be used as the mainstay for why to do something. If you look here, you can see the estimate number of outpatient ivermectin prescriptions dispensed from retail pharmacies in the US. And although we don't have data into September, the evidence is that the numbers are growing substantially in humans. In addition, if you look at what it's doing is actually hurting people. And in the very bottom paragraph here, calls to poison control centers about ivermectin exposures have risen dramatically, jumping 5-fold over their baseline in July, according to CDC. And this is a huge issue. This drug is not just not effective against COVID, but it's actually dangerous at the levels that people are taking it. Yet it continues. So horse owners no longer can find ivermectin as Americans flock to unproven coronavirus cures here. This is a drug that has been used to treat horses that have basically had parasitic infections, can't find it. And the irony of it is, here we have people who will not believe in coronavirus this data, but they actually, and they believe that it poses a greater risk than the disease itself, and so won't get it. But at the same time, they're willing to take ivermectin. And this has become a real challenge. So what drives support for COVID vaccines currently recommended in the US? Large clinical trials with rigorous and careful review prior to authorizations, hundreds of millions of doses in the US, outstanding safety profile, and significant reduction in risk for infection, severe disease, and death. In terms of clear, robust, and compelling data, COVID vaccines are in a league of their own. Nonetheless, here we are living in a world of ivermectin and not willing to take a vaccine. We even have the situation now where we have individuals who are suing hospitals so that people being cared by that hospital for COVID-19 are required to give ivermectin. And at this point, fortunately, it has been largely successful where hospitals are able to keep from doing this. But imagine family members who wouldn't vaccinate their loved ones are now in court fighting to get ivermectin used. So let me just conclude quickly here on the poor quality data and its interpretation and how it confuses the public. Another, I think, misuse of data. If you look here, this is data from the ACJIH, which is the scientific organization basically of industrial hygienists and people who work in the area of aerobiology. This is a slide that shows if you time to infectious dose for someone not infected with COVID-19. So on the left, the source is wearing, the receiver is wearing on the top, meaning if you have nothing for either one, no face cloth covering of any kind, any protection, within 15 minutes, one could be infected being in the room. This is enough concentration over time to have an infectious dose. With Delta, we actually think this number is even much lower. But if I'm the wearer and I have a face cloth covering on, the leakage that occurs with that would only give me 20 minutes of protection, 5 additional minutes. If I have a surgical mask, I get 15 minutes of additional protection for 30 minutes. If I wear an N95 10% filter, I get at 2.5 hours protection if it's not fitted. If it's fitted, 1%, I get 25 hours. The point I'm trying to make here is that face and fit are very important with an aerosol. With a virus, it's transmitted by something like smoke would be. In the sense, if I were in a room and somebody's smoking, if I could smell their smoke, then I could also be breathing their aerosol. Well, I bring this up because we have gotten off on a whole series of studies that have recently come out showing how masking, without any definition of what a mask is just a piece of cloth over your face without regard to face fit or filtration. Here's a study that recently came out from Bangladesh with 340,000 adults, received lots of attention in the New York Times. Here's one that came out also in the New York Times, studied 1 million students from a group in North Carolina. Here's another study that just came out, limited mask limited COVID transmission on unvaxxed college kids. And here's another one that just came out with regard to an elementary teacher likely infecting students in a class who they themselves had masks on, but she took her mask off to read. The point I want to make is all these studies had significant study methods challenges, none which were discussed. None of these received comprehensive peer review before being reported in the media. So we just keep piling on with study after study that masks work without regard to what is a mask, number one, and with that figure I just showed you can see that's a challenge. And second of all is the fact that it's a situation where When we talk about protection, what does it mean by time? How much dose? How close are you? And in fact, this is a series of studies that have been done, actually supported by the Center for Medicare and Medicaid Services. And this is a group that basically specialized in evidence-based practice. And they have been reviewing studies, and their most recent update is in September, and they have more. And in short, they find, as concluded with prior updates, there are no studies on the effectiveness and safety of mask reuse or extended use. Basically not finding that studies that we need right now have met the criteria for valid and scientifically sound studies. So what you're hearing about in the media day after day is, yes, people are reporting these results, but when you dig into the methods and you dig into what they really have been doing, these are really challenged. Now, I'm not anti-mask. I actually think everyone should be wearing a KN95 or N95 respirator as the basic set of protections that you have in the environment. But the point is, just to put a face cloth cover on your face does not do that. The role of mask here, masks may play a role in disease control, but public health officials should not oversell the role of mask, and we have. Rather, we need to encourage appropriate mask use in the context of other highly effective interventions such as vaccination. If you're going to wear a mask, wear it over your nose. Scientists must provide the highest quality scientific evidence and its accurate and fair interpretation, so policymakers can determine how best to protect public health by implementing sound policies. I find this cartoon unfortunately sad, but real. Gentleman here looking at his computer, honey, come look, I found some information all the world's top scientists and doctors have missed. I see this over and over and over again. Public has now its own set of facts. They have their facts, we have ours. Unfortunately, the political reality has now become the science reality. I don't know how we recover from this because it has become such a huge challenge in public health and medical practice. So let me conclude by saying, what are the lessons learned about the use of data during the pandemic? First of all, I got to just be honest, good luck. What we've seen in the examples I gave you today are just some of the challenges we have with data being a gold standard four-letter word. Even high quality data will be challenged in how it informs medical and public health practice and public acceptance. Vaccine and treatments are two right there. The issue of masks or how to best protect individuals. We're in an unprecedented place in the evolution of scientific investigation where alternative facts are accepted by many as valid for making critical decisions. I've never seen anything like this in my 46 years in the business. The scientific community, while critical of mis and disinformation, has contributed to the public confusion regarding the use of scientific data. We ourselves have not been clear on what should be the standards and how should we judge the scientific validity of data. Finally, a post-pandemic review of scientific data with regards to how it's generated and used will be critical. We absolutely have to have that. And if we don't, we will find that this situation will not change, and I fear will actually make data and its use become not obsolete, but challenged in a way as to really cripple the potential positive impact that it can have. So I hope this presentation gives you some sense of the challenges we are currently experiencing with this pandemic and the use of data, and I look forward to our discussion. Thank you so very much.
Welcome back. I'm here again with Carl Larson of the Department of Health and Exercise Science. And we have a little bit of time to talk about Dr. Osterholm's talk before we switch to another of our panels. All of our panelists will be joining us in about 15 minutes. And just a reminder, if you have any questions for Dr. Osterholm or Dr. Domenici, or for really any of our panelists, submit those to Nobel Conference at gustavus.edu. Also, we have a poll that's open now, again, inspired by Dr. Osterholm's talk. You can get to that by going to pollev.com/Nobel57. I've heard from at least one person who said they were having trouble with the poll. When I tried it all lowercase, it worked for me. I'm not saying it will work for you, but give that a shot if you're having trouble. pollev.com/Nobel57. You can also text Nobel57 to the number 22333. And Carl and I will talk about that poll in a little bit. But to turn to some questions that were raised by Dr. Osterholm's talk, Carl. So masks. What would you like to, if you could reinforce or reiterate something that you heard Dr. Osterholm saying about masks, what would you emphasize?
Well, I would start with the idea that the issue is not anti-mask, it's pro-fit. That's the really important component that gets missed in the conversation about whether or not masks are effective. We know that when surgical masks are used and when NK95 masks are used, that they have an effect or you have a greater window of time in which you can prevent transmission. So I think that message is really important. I think what he's trying to say is how important it is to make sure that the only information we're sending out into the public is stuff that's been sufficiently researched. And we moved quickly on the masking idea. Just as a background to that, I think it's important to note that when you have a significant outbreak like we're dealing with, and it's new, right? It's called a novel coronavirus for a reason. We've never seen this before. We have to start with what we know. And that was, presented some initial issues in the beginning because we presented what we knew. It turned out some of it wasn't really where we needed to be doing and where we needed to be. So starting out behind the 8 ball didn't help us much. I think another important message has to do with this, the criticisms really that come from some of the more trusted sources that we have who are delivering information related to the pandemic. He touched on several different organizations that routinely put out information on the pandemic, and the idea that those are always accurate really comes into play. And I think we just need to be a little more cautious about how quick we rush to put information out and how far down the road we look when we put that information out.
Something I think about a lot when I think about this question of masking is that there was a very good reason that we were all wearing cloth masks at the beginning, which was that there was a terrible shortage of N95 respirators, and so we were all, making them out of terry cloth dishcloths or whatever we could find, right? I mean, vacuum cleaner bags, the really crazy things, because there quite literally was no supply of those. So now it's difficult and challenging to roll back something that we've come to accept as like, well, that's what we've been doing. Why isn't that okay? We were also washing our Doritos, Carl.
Correct.
Back then.
Yep, we were scrubbing everything down at that point. And I thought it interesting too that, at one point the message was any sort of covering is better than no covering whatsoever. And one of the most common things I saw that I would talk to people about is they were using those stretchy, dry fit kind of things that go around your neck, and they would just pull them up over their nose and over their face. Dry fit's kind of specifically designed to let moisture out, right? So it really wasn't the right kind of cloth that we needed to be protective. And you're right. Washing your hands and scrubbing everything down, and then we learned it's not really vector transmitted. So, the beginning was tough. We had a lot of hurdles to get over early in the process.
Which is about how science works when it's actually in the discovery phase.
Yeah.
Right. So I wonder if you can talk about, what's something from his message about the nature of science that you take away that has you worried, maybe?
I think I'm more worried about people being anti-science, if you want to know the truth. That scares me more than anything. And maybe it's what we do for a living. Maybe it's being in this intellectual environment and sharing ideas and bantering and discussing and disagreeing that we do every day that makes me wonder how folks just simply turn their back on all of that. And the idea that we will forego scientific evidence for something that's trendy or unproven or just doesn't have the scientific rigor behind it that would make us feel comfortable enough to promote it as a method. Really, that makes me very nervous.
So I'm really curious, and because I know you're in public health, I'm curious about the degree to which the novel coronavirus is behaving in just ways that stymie everyone in novel ways. So did I hear him correctly when he said that the virus sort of burns itself out before it's run out of people that could be infected by it, and then it kind of moves on to the next state? Did he say something like that?
Well, I think that's what I heard as well. And that makes this particular virus awfully puzzling, that it would have its own intellect, if you will, that it knows when it's gotten to a particular percentage of the population and it would have to back off in order to sustain its own ability to transmit and survive. I really think that's one of those things we're going to have to throw out in the panel. And specifically, it'd be interesting to see if there was some way to use machine learning to track that particular cycle and whether that could help us in the prediction of where and when it might happen.
Which leads to a question. Can you talk about how this ties back to big data? I loved the passage or the quotation he began with about, it all tracks down to the, to the village watchman who's recording the rainfall every night or whatever the thing is, right? And, with a stubby pencil. And that I spilled coffee on that page. So can you talk about, why and how all of this really comes back to, the relationship between those individual recorders and these terabytes of data that we're talking about? Why does big data matter here, Carl?
Well, I guess the sheer accumulation of health information that we have, and not just related to coronavirus, but to all health issues and health disparities that's out there, is enormous. It's tremendous. The databases are so large that even just to dive into one particular health-related issue, the data is too massive to do on a small scale. We do have a significant reliance on the village watchman. We have people in the local communities. Think of the weather on TV, right? When we do the weather report on the 6 o'clock news, those reports they get for rainfall are coming from people who've got little plastic measures in their backyard. Even down to that level, we're relying on people to gather and distribute accurate information. The whole idea behind the village watchman that I think is still super important is this idea that you have someone or someones who are taking responsibility for managing the health status of their community. I think that's really important. We certainly need to work on how well we do that and how accurate that is. We're always working on the better accumulation of information. But I think that we've moved away from that a little bit, the idea of the village watchman, and we've become more of I'll take care of my own stuff. I don't need you to get involved with this. And if we back that up just a little bit and we were able to get more people to have a greater level of concern about the community's well-being as a whole, we might be able to have better and more productive conversations about how to do that and not get all beaten down in these conversations about individuality. So to me, the role of the village watchman is still a really important one. How we get back to a point where we're all having conversations about what's best for the community, I think is one of the challenges that we're looking at right now.
Really well put, Carl, thanks. Let's see, looking at our clock, I think I'll save my question about modeling for you to ask during the panel. And instead, reminding our audience to take that poll at pollev.com/Nobel57. And so, Carl, the question was, the Minnesota Department of Health implemented the mobile app COVID Aware to assist in contact tracing. And so we just asked people to tell us what they did when they got that notification, and we're going to.
Curious to see
Yes,
how this turns out.
I'm curious about this one as well, Carl. So we'll see some results from that poll. So there were 4 possibilities. You want to talk about what you're seeing there on the screen?
Wow, is my initial reaction, where 42% of our people had never even heard about the app. That is
sobering.
really surprising to me. MDH had a heavy marketing campaign on this early on in the pandemic. That number surprises me greatly. I downloaded the app as soon as I heard about it and had no privacy concerns, about 1 in 4. I did not download the app because I was concerned about privacy and security, about 1 in 4. Those numbers don't surprise me. I'm wondering just instinctually here, or impulsively off the top of my head, if that has something to do with the political polarization of this particular issue, because that was well underway before the app came out. And we certainly had people who were willing to buy into some degree of inaccurate information related to what the app was really designed to do. And so there were people who were very concerned that if I download this app onto my phone, they're going to track me. They're going to know where I go and what I do. And I don't want people knocking on my door asking me about COVID and those type of things. And that kept a lot of people from going to use it initially, at least those who knew about it.
Yeah, it's interesting. As you point out, Carl, the number of people in those first and third categories are hopping back and forth a little bit, but solidly at 47 or 48%. I never heard of this, is sticking right in there. That's very, very sobering indeed.
Well, I would imagine our folks at the Minnesota Department of Health would really like to know that. Now, these are really informal,
exactly right.
unprofessionally
done. This is not a scientific poll, friends.
Yeah.
It's you're choosing to answer, so, you know.
They might have a problem with our sample.
Yes,
yeah.
Indeed, yeah, indeed. Wow, that's fascinating, though.
Yeah, well, the numbers are remaining pretty consistent, even though those who are still chiming in, there's not been a lot of movement in the 45 seconds or so that we've been looking at it.
Yeah, exactly. Interesting. And, well, it looks like we maybe do have a little bit of time before our panelists join us. So I am just going to ask you to react, perhaps, to the way in which, very direct way in which Dr. Osterholm said, look, all models are wrong. Some of them, however, are useful. So was that a useful thing for Dr. Osterholm to say?
Yeah, I believe it is. And to me, what it does is it brings us back a little bit, gives us a bit of a reality check. It's that idea to remember that when we're using modeling, what we're doing is trying to project, and there's a timeline to which that might be effective, and an extension beyond that timeline is in many cases counterproductive. And he showed many examples about how and why that happened.
Right. And again, it's a model. A model is not the thing, right? It's a model.
Right.
Right. When you build a model airplane, they encourage you not to actually try to fly in it, right? So models are simulacra, right? That's probably not the right word there, actually, but you know what I mean. Well, it looks like our panel has assembled itself, and so I think we can welcome them aboard.